Good morning, everyone. My name is Romain Sonneville. It's a pleasure to be here at the ECMO 2020 to discuss brain injury in VA ECMO patients. I have a conflicts of interest slide. I have no specific conflicts regarding this presentation. So, brain injury in VA ECMO patients, what are the main complications? We know that hypoxic ischemic injury has been described in VA ECMO patients, and we also know that cerebrovascular complications may occur in the form of ischemic stroke or brain hemorrhage, ICH, intracranial hemorrhage, subarachnoid hemorrhage, and also microhemorrhages, microbleeds that are best seen on MRI scans. Diffuse cerebral edema has also been described on brain imaging, resulting both from hypoxic and vascular complication at the acute phase. This is one of the first single-center study that assessed neurological injury in adult patients treated with ECMO. You can see that neurological injury was quite frequent, 50% of patients, with various lesions seen on brain autopsies. And we can see that among brains studied, we found, the author found ischemic or hemorrhagic lesion is almost all patients in this seminal study. A more recent autopsy study conducted in 25 ECMO patients who had a postmortem brain autopsy. We can see here that hypoxic ischemic injury was diagnosed in almost 1 out of 2 patients, and that among cerebrovascular complication, ICH was found in 25% of patients, with SAH being the most prevalent form of hemorrhage. Ischemic complications were found in 60% of cases in this recent cohort. What about clinically defined complication? This is a nationwide inpatient sample conducted over 10 years on more than 20,000 patients on ECMO, all ages, all types of ECMO. And you can see that the neurologic complications, vascular complication occurred in less than 5% of cases, ICH 3.6%, ischemic stroke 4% of patients. Data from the ELSO registry from 1992 to 2013 on more than 4,000 adult patients on VA ECMO. Neurological complications were observed in 15% of cases, irrespective of ECMO indication. Cardiac patients are more frequent neurological complication, and if you stratify by indication, you can see that the rate of neurological complications is much higher in patients who had ECPR before ECMO run. What about cerebrovascular complication in this series? Again, less than 5% of cases, with ischemic stroke being the most frequent, 4% of cases, and ICH 2% of patients. So what are the risk factors? We know that risk factors for brain injury during VA ECMO may be patient-related, such as older age, pre-existing cardiovascular risk factors, chronic cardiomyopathy, arrhythmia may contribute to stroke and brain injury. Critical illness itself, including, of course, pre-ECMO cardiac arrest, hypoxia, hypoperfusion, sepsis, DIC, may contribute to brain injury. And ECMO-related factors may also be prevalent, such as altered or severely altered CBF during ECMO support, platelet activation, and anticoagulation. In this multi-center study, again, risk factors for neurological complication were addressed by means of multivariable analysis. And you can see that among non-modifiable factors, older age and indication for ECMO were positively associated with neurological complication. Cardiac arrest, septic, and cardiogenic shock patient had a greater risk of neurologic complications. This is data from the group of Lapitié in France, where the authors on a single center study tried to address risk factors for ischemic complications. And they found that central cannulation and thrombocytosis were independent risk factors for ischemic complications, whereas risk factors for hemorrhagic complications were female sex, central cannulation again, and by contrast, a lower platelet count, thrombocytopenia being independently associated with brain hemorrhage. Special attention has been paid to early changes in the PaCO2 after ECMO initiation. This is a large multicenter cohort study where you can see that both hypo and hypercapnia following ECMO cannulation are associated with an increased incidence of neurological complication. There are several underlying mechanisms that may contribute to brain injury due to early change in PaCO2, including cerebral vasoconstriction, increased neuronal stability, leading to decreased cerebral blood flow and increased cerebral metabolic demand, respectively. After adjustment for confounders, including pre-ECMO cardiac arrest, renal and hepatic failure, you can see that the massive drop in PaCO2 remained independently associated with the occurrence of neurological complications. So, do we know if neurological complication and brain injury impact outcomes? The answer is clearly yes. Again, from this large registry, you can see if you compare patients with and without neurological complication, you can see that ischemic stroke and ICH patients were less likely to be discharged home, more likely to be discharged to a long-term facility. They had a higher length of stay in ICU and hospitals and increased hospital costs. We know that cerebrovascular complication, ICH, notably is an independent predictor of hospital mortality after adjustment for age and indication for ECMO. So clearly it impacts outcomes. So one key question is how to monitor the brain during ECMO support, because we know that there is no practice guideline or management strategies for the neurocritical care of those patients. We also know that clinical evaluation is quite difficult, and neurological evaluation at bedside may be confounded by sedative infusion and neuromuscular blockade. Use of special scores, such as the 4 score, may be of help to have greater detail on neurological findings, including brainstem, reflexes, breathing patterns, and the ability to identify herniation may be easier. We have automated tools such as pupillometry, which has been studied in ECMO patients, and we know now that pupillary abnormalities identified by automated pupillometry are associated with poor outcome, and pupillometry is able to identify patients at greater risk for neurological deaths at 90 days in this recent Swiss study conducted by the group of Moro-Odo. Biomarkers have been studied during ECMO support. Markers of astrocytic injury may help to detect cerebral complication. This is a preliminary study, S100B levels measured on several days during ECMO support, and you can see that higher values are observed in patients who developed brain complication under ECMO. This is preliminary data on adult patients where you can see that the marker of neuronal injury, neuron-specific NLAs, also identified brain injury during ECMO support. These are patients with and without stroke diagnosed on neuroimaging with NSE values measured at day 1, day 3, and day 7. And there's a bit of overlap between groups, but you can clearly see higher values in patients with brain injury. Other biomarkers have been studied in the pediatric population, including other glial markers such as JFAP, which also seems to be higher in patients with brain injury or unfavorable outcome compared to patients that who will do good. This study also found interesting result on NSE and S100B. But if you take a look at the AUC to predict outcome, you can see that clearly this is not very good, 0.7 or 0.68 for JFAP and NSE. If you combine biomarkers, it increases a little bit, but it's not enough to be used alone at bedside to rule out brain injury, of course. What about EEG? We have data on both standard and continuous EEG at bedside with evaluation by expert neurophysiologists blinded to patient's condition. And we know that standard background abnormalities on standard EEG and sleep transients or loss of sleep transients on continuous EEG are associated with poorer outcomes. These findings were recently confirmed in a recent study where you can clearly see again the prognostic contribution to assessment of background frequency and background abnormalities on standard EEG. In this study, the strongest indicators of poor outcome was a lower background frequency at ECMO initiation after adjustment for age, non-neurological SOFA score, and pre-ECMO CPR. Cerebral near-infrared spectroscopy has been also studied and is clearly associated with a higher risk of acute cerebral complication and mortality. This is a group study from the group of ERASM in Brussels. It was published in 2018. So to conclude, several things may help to prevent brain injury during ECMO. At ECMO onset, optimize cerebral perfusion, avoid abrupt PaCO2 drops. Early assessment of neurological status is mandatory with multimodal, non-invasive bedside evaluation with different available tools. Repeated brain imaging may be of interest. And then targeted intervention might help, lower anticoagulation targets, higher transfusion threshold in specific conditions, and of course also optimize ECMO weaning process to avoid brain injury during ECMO. So in conclusion, brain injury is frequent in adult patients under VA ECMO. Most frequent patterns include hypoxic ischemic injury and ischemic stroke. The risk factors include, of course, pre-ECMO cardiac arrest, but other risk factors have been described in the literature. Brain injury may significantly impact therapeutic decisions. It contributes to poor outcomes, and early multimodal non-invasive monitoring is mandatory for detection of brain injury and also to assist with prognosis. And with this, I would like to thank you for your attention.